Okay, we're all set.
All set, sir. Thank you.
Okay, well, it's a pleasure to have today on a grand round Dr. Antonio Anzueto. Dr. Anzueto is a professor at the Department of Medicine, Division of Pulmonary Diseases, and he's going to talk about COPD. It's a treatable disease, and you can make a difference. Thank you, Dr. Anzueto.
Thank you, and thank you for the invitation. It's truly a pleasure to be here with you all. For a start, I need to give you my disclaimer because I have a lot of conflicts. Everywhere you turn around, I have conflicts. So I have conflicts because when I talk about gold guidelines and recommendations from society, I'm a member of those committees. I have conflicts because I work with all the pharmaceutical companies who make antibiotics or bronchodilators. I have conflicts because we do clinical trials with all those medications here. The bottom part of the grants is a great deal because I have to pay the bills, I have to balance the book, and the university gets the money. So that's a better deal. We're even mapping the VA for us, so that's okay. So, if you look at this paint, what do you think it is? What do you think this paint reflects? What do you think the paint? Just know whatever comes.
It's a person.
It's a person? What else have
I
you?
guess, I don't know.
So it looks like a person with nose, body. Anything else?
Is it Cyrano?
Say it again?
Is Cyrano de Bergerac?
Not what looks like him, certainly. Very abstracted, these things. Well, so this is Picasso's impression of the paint on the left of the Matador. And actually he painted this for a friend of him who was a Matador, and basically that was his interpretation of how he looked at him. So the point I want to make is that we do have a perception about COPD, and my goal is to change that perception. Whatever you have thought, what you feel about it, when you can put it aside and just look at it very fresh, this disease. The reason being is that you look at this lady, she's a 47-year-old that has cough in the morning, wakes up, and must be allergic to something. And you look at this lady that she was a teacher, she's 55, she used to smoke, doesn't smoke anymore, and she's always tired, and had been called that she had bronchitis. So there was a study done that these profiles were presented to providers, specialists, primary care, nurse practitioners, physician assistants. And if there is a male, over 80% of the time the diagnosis was COPD. If it was a female, the diagnosis was allergies, asthma, all of the above, not COPD. So, the three things that I want you to remember is that this is a treatable and reversible disease. This is a disease that the management should not be limited only to bronchodilators or rehab or smoking cessation. You need to put all those three stuff together. And the standard of care today is not Anzueto and ipratropium every 4 to 6 hours. The standard of care today is long-acting bronchodilators or therapy. And that applies as an outpatient, that applies as an inpatient. It really appalls me that every time a patient gets admitted with an ingrown toenail that has all these medications for respiratory, they put Anzueto and ipratropium every 4 to 6 hours, then develop FA, RVR, enter an ICU with an atrial fibrillation. But the other medications that for the blood pressure, stuff like that, they just copy the same. You know, why we don't do the same for the respiratory medications? And that's the point that I want to make. This is a disease that it grew over the shadow of asthma. So it's like you have a big brother that is excellent and going to Harvard, and he's GPA 4, and he's the star, and you're coming behind, and you're pretty much the other side. Everybody tries to compare you and try to do everything because as easier as everything. But we are finding out every day that this disease could not be much different than asthma. Actually, they're 180 degrees separate completely. So this has created definitions, it has created assessments, and there is a huge amount of molecular biology, cellular level that's showing the differentiation. So we recognize that the disease, I told you before, is preventable. If you happen to smoke or the patient smokes, they should smoke. You should never smoke, you may never get it. It's a treatable disease, and if you don't do anything, the disease will progress. So what happened during the 1990s, the other alternatives that we have was Anzueto and ipratropium. And I will see my patients will We get them in clinical trials, we've been doing short-acting bronchodilators, and they will come to me and say, well, why I'm more short of breath? Why I'm in oxygen? Why I'm in a scooter? I took the medication every 4 to 6 hours. The wife will come and say, listen, he woke up at midnight to get his medication. Why is his disease like that? So we say, well, this is a progressive disease, plus you smoke, so it's your fault, so that's the way it's supposed to go. I'm going to show you that that's not the way it's supposed to go. What we didn't know in the 1990s is that short-acting bronchodilator equals nothing. So you want to waste your time, you want to waste your money, give them that, because it's not going to do any effect for the disease. And the final point is that as a pulmonologist, I like to think about COPD as the disease of the lungs, and it makes it much easier for me and more comfortable. You know, I just say, what bronchodilators I on, what this, okay, next. But the truth is that the patient who has COPD, they have high blood pressure, has diabetes, has hypertension, and CAD, has all of the above. There has been some people who are suggested that we should have this systemic inflammatory syndrome, but all this stuff will come together because it's all they are interrelated. I don't have diabetes in my practice because I don't check for glucose on anybody. I don't know if I have diabetes. So your patients in your practice don't have COPD because you're not looking for it. So I'm going to show you in a minute what you have to do to look for it. So there are the two issues here and how the face of the disease is changing. Today, more than 70% of the newly diagnosed patients with COPD are under the age of 65, and a significant number are women. As a matter of fact, more and more clinical studies are showing that the ratio between men and women is around between 55 and 60% women and 40% men. So there are more and more women who have this condition. And the problem in women doesn't get recognized and doesn't get diagnosed. And just to make that point, this is a cohort of a 4-year study of an intervention. And when they analyze women and men, you can clearly show that the ladies had more exacerbations than men, all across the board. And there is data that are demonstrated that in women the disease progresses like 10 years faster than men. So if the woman gets diagnosed in the late 50s, will be like men in the late 60s. I have in my practice close in Mark, several ladies, a lady that we follow with Mike together, that she was diagnosed in her late 50s. She's severely incapacitated on oxygen, in scooter, now 15 years later. And I have many patients like that because we never thought that they could have this disease. So not only progresses faster, we don't think about it. And that's what we need to do now. Because this is a geriatric grand rounds, I thought we probably should look a little bit about does age make a difference? And I tell people, if your patient is over 70 and you think we may have COPD, don't worry about it. Because the truth is, either they don't have it, if they had it, already died of it because they may have heart disease, diabetes, high blood pressure, and all the above. So the disease has already been diagnosed. The disease doesn't seem to have a major difference by age. This database will allow us to see, significant number of patients, and you can see that over 1,500 patients in the more than 70 and 2,500 patients in the 60 to 70, and the overall group, the older patients will tend to have lower FEV1s, but the distribution is moderate, is similar to the other groups. They are no more severe than before. And I think my bias, what happened now, is that people who were diagnosed in their 60s and getting into their 70s now, and it's being treated appropriately, what you happen, the disease has stalled. So they are not progressing into getting more severe disease. Now, so how we diagnose this condition? This has to be a combination of suspecting by symptoms, suspecting by risk factors. You must do spirometry. There is no other way you can diagnose this disease. If you don't do spirometry, you can diagnose, and this will be the equivalent that I come and tell you, listen, I have this wonderful pill that will decrease the blood pressure. This is the medication for arterial hypertension. So we're going to divide the room. The people on this side of the room are going to take the pill. That side of the room are going to take placebo. We're going to meet again in 4 weeks, and we're going to measure your blood pressure to see the effect of the medication. So you say, this guy is nuts. I'm going to take a medication, I don't even know I have the disease. So think about it, that when we look in our pulmonary function labs and we look for cases and patients to do our studies, So we pull out spirometers from there, and then we go into the computers of the institution, and we see, well, I want to see people who are in complement, I want to see people who are in short-acting bronchodilators, over age of 55, stuff like that. Put it together, it turned out to be close to 60% of the people who get short-acting bronchodilators here have never had a spirometry. So it's identical to what I told you before. You've been treating for the disease, you didn't know they have the disease. So you have to do a spirometry. Now, all these gentlemen, they answer an advertising that was, we're looking for men and women of age of 45 who have smoked more than 10 pack years. That's what they came. None of them had ever had a spirometry, had been diagnosed. On all of them, their FEV1 was less than 35%. They all had very severe COPD. They all have high blood pressure, diabetes, and all of them. And none of them have been on therapy. Now, one of the issues that makes this disease complicated, and it's not complicated, but it has many phases, is, and there's a lot of this, the buzzword now in COPD is the phenotype. So what are the phenotypes? You know, can we put patients in different characteristics? And until you COPD phenotypes is like the word car. If I tell you car, C-A-R, in your mind will come thousands of images of color, size, doors, shapes, everything you can think about. Always meets the frame purpose. Comes from point A to point B. It's a mobility, but it's going to have many, many ways to present. So what happens in COPD is patients will have many different forms of the presentation. And at the end of the day, we have to have some common denominator to call it a disease or not. And that's what we use as spirometry. For example, all these people have smoke, all have the same risk factors. You look at the CAT scan on the left, his FEV1 is normal, the diffusion is slightly decreased, and has significant bulla disease. The one in the middle, both the diffusion and the FEV1 are normal, has significant bulla disease. The one on the right has very severe COPD and has perfectly normal CT. So there is no correlations, there is no interactions. And with that, I can start adding to the question symptoms, I can start adding risk factors, there will be a common denominator. Then I can start adding what happened with the intervention. Some people have more exacerbations, some less. So there are many, many phenotypes the disease is going to have. So at the end of the day, we define if your patient has a ratio less than 70, that's the actual ratio in your spirometry. I have to confess to you, when I read all these reports from here, that is a page long that has like 20 numbers down the row. Nobody knows what those numbers mean. I mean, I don't know what those numbers mean. The FEF 2575, the FEV6, nobody knows what those mean. And in
some physiologists got their PhD.
Well, some physiologists got the stuff like that. And you can go to our international conference. We have these lengthy debates and discussions for hours of which we use. Don't worry about it. This is what you need to remember. The ratio is less than 70, you have obstruction. The ratio is more than 70, you don't have obstruction. And then your FEV1 will give you the percent of predictor, the severity. Now, when you look at a spirometry, I think you should take 30 seconds to do two things. One is read the patient's demographics. So the person who's sitting in front of you is a 65-year-old male who weighs 120 pounds and is 5'5". That's exactly what the demographic says. If the demographic doesn't say that, the predictors are going to be wrong. And then the second thing is you always wanted to see a graph. We're working very hard to get here eventually the graph into the report that you get. Because with the graph, it doesn't matter which graph you see, flow volume loop, or any relationship. The graph is nice and smooth, you are fine. The graph is like this, those numbers are trash. So you don't believe those, you just throw it away, you just move. Now, one of the issues of the pathophysiology, this is the only physiology slide that will be here, is that how we understand how these the process that occur in our patients. So they develop the obstruction, but the primary mechanisms is airway hyperinflation, and that's what you see on the chest X-ray. So what airway hyperinflation does, it neutralizes your respiratory muscles. So our diaphragm is a dome. It's a curved muscle. Our diaphragm is the largest muscle in the body. And what part of the cow is the diaphragm that you eat? fajitas. So you know very well, if you get a fajita taco and you didn't cut it right, you're gonna be like, you're not gonna get it. Because they are single fibers, all the way out there. So that makes it to be very inefficient, and at moments of stress, it cannot get a lot of blood. Actually, a patient is breathing 40 times a minute, it sucks huge amounts of blood. And also, when you have hyperinflation, your diaphragm is flat, it means your diaphragm is not working. Because the work of the diaphragm is to do this. It's like, for example, you say, oh, you have your biceps, your tricep, how much strength you have in your biceps? Okay, measure it here. I mean, I'm a complete contraction. You cannot measure either my bicep or triceps because it's neutralized. And that's exactly what happened with those patients. So when they don't have a diaphragm to work for them, they need to use the accessory respiratory muscles, and they have to use the rib cage and all of the above. And the first thing you notice is you see the patient breathe. You look upon yourself here, I don't see any of you breathing. I mean, breathing is very effortless. One of the hobbies that I have is when I'm in the airports and flying very often in the airport, I watch people breathe, and it's amazing. I mean, it's amazing how you can be next to somebody walking and you can see a person, how the expiration is very forceful. Expiration is the passive part in our respiration. You can put tonight a piece of paper in your tummy, so you're going to see how that paper goes up a little bit, and so that paper comes down, and you haven't done anything for that. And you may want to say, we're going to breathe in a little bit, kind of push that up, but then the expiration is passive. And our patients sit at the side of the bed, they take a short breath in, and they have to push out. But they're pushing out not only because they have obstruction, they push it out because they're hyperinflated. So you are hyperinflated, you're going to have dyspnea. You want to test a little bit of how much dyspnea these patients experience tomorrow morning. Get in the shower, get a timer, put it on 5 minutes, and start breathing 40 times a minute. Just kind of, I try to take a shower like that. That's exactly the same level of dyspnea that you're going to experience that these patients do. And you're going to have to stop. You're not going to be able to continue. The good thing is you can stop. And you can do normal, they cannot stop. So you are dyspneic, you do less, you become more deconditioning, that fits the vicious cycle. But the worst part is that it's not that stuff is not only bad, this stuff gets hammered over and over and over. And when you hammer it, it's done by exacerbations. So exacerbations, now we know that are the equivalent to the acute coronary syndromes in CAD. Exacerbations are the ones who drive morbidity and mortality because they further decline lung function and further compromise the patients. So as you put all this together, you look at percentages, this disease is associated, significant number of patients have depression, anxiety, cardiac disease. All this is a big soup. Everything that you see is going to all be intertwined together. So what happens if you don't do anything? 40 to 50, 50 to 60, 70 to 70. That's exactly what happened. So we have to change this. This is not acceptable today. So what I'm going to do? So let's need to make a big jump and start thinking. So we need to set up objectives. What do you want to accomplish? So when you see your patient, you have to tell them, say, what do I want to obtain for this? And if you read this, and if I change the title from here, for COPD, if I change to arterial hypertension, you're going to see they're going to be identical. Because in blood pressure, your goal is not to have the blood pressure 170 or 80. Your goal is to prevent the complications of hypertension. And as a matter of fact, there is a paper in New England, a really nice paper, several years ago, they compared Lasix based to the ARBs. And the first graph shows you the decline in systolic and diastolic blood pressure that is identical with the diuretics and the ARBs. So why you use ARBs and why you go to table 2 and what the papers in New England is because it has significant decrease of cardiac events and deaths with the ARBs, something you don't achieve with the diuretics itself. So the medications do more. So here, as we wanted to relieve symptoms and improve exercise, our ultimate goal is to decrease complications and decrease mortality. You want to do this with 3 ways. You put all these together. They happen to smoke. Turned out to be that doctors who were the major proponents, major proponents of smoking. In the 50s and 60s, all the advertising says, my doctor smokes, it should be good for me, so I should smoke. So you can see from everybody there.
What proportion of chronic obstructive pulmonary disease is tobacco related?
Sure. So there are two that new and there information that is actually coming more. The National Institute of Health funded 5 years ago a study called COPD-G. So to enter the COPD-G, you have to be over 45 and has to smoke more than 10 pack years. So they're all smokers. And what this is changing the way we think of the disease, it turned out to be that everybody who smokes develops some form of lung disease. So the teaching that we had is that only 25% of smokers develop COPD is wrong. And as a matter of fact, there is no correlation between how many packs and severity of disease. So we very often we focus on saying, okay, you smoke how many years? So you are 100 pack a year, you should be very bad. But I have a friend in Minnesota that was my uncle's neighbor, that he lived to be 103 years. He smoked until he was 99. He buried 3 wives of all age. He did a square dancing when he was 102. And the guy developed a disease. He coughed. He had moderate disease. And you're also going to have people who have smoked very small that have severe disease. So the first part to answer your question is if you do a correlation by disease severity, this is mild or goes 0, 1 to 4, and you put here number of packs a year, the relationship is like this. There is no correlation. So this is what makes the urge that you have to smoke. It doesn't matter how severe the disease. Now the other side of the question is, what percentage of people that don't smoke, what percentage of COPD is non-smokers? And most of those patients are going to have something. For example, in all Latin America, all in the Far East, we have the exposure to wood smoke. So I had a couple of patients, so they never smoke. Nobody smokes around them, so they don't have secondhand smoking. Secondhand smoking can also give you injury. And we learned that in the 1960s. The first people, the first groups, the population that really recognized the dangers of smoking were the flight attendants. The flight attendants sat in the back of the plane in the 1960s and they started having lung cancer. And they said, oh, you know why they're having some, and it turned out to be somebody, this epidemiological, it was a huge spike in flight attendants and lung cancer that didn't fit. It was because all the smokers sat in the back of the plane. And the filters were not small enough to filter to clean that out. So that association was established. So secondhand smoking is the truth. So once you have ruled out everything around there, this wood smoke is very relevant, it's important. There are extensive studies done all around the world, and that would carry you on. So you may have never smoked, but you were exposed when you were 0 to 15 to that, you will develop chronic obstructive lung disease later on. The children of smokers. So in your house, your parents happen to smoke like a chimney all day long, and you smell that, and you were like that, you grew up like that, and you're up to 15, 18 years, you left home, you're in your 40s and 50s, you will have obstructive lung disease. You have more reactive airway disease, you're going to have disease. Another exposures related mines, the mines you will have that, close environment. And there is a lot of argument, is pollution, environmental pollution can do it. That has not been able to demonstrate. As a matter of fact, there is a study called Latino that was done in Latin America. This was a population of 8 major cities that basically was a population spirometry survey. Mexico City, who has the worst pollution, is no worse than Montevideo, who has the less pollution, but it turned out to be that the factor there is age. In Mexico, much younger, so it's probably less likely to have developed disease. Like in Montevideo, the population is in their 70s, 60s, and 70s, so that's the reason they have more COPD. So, why you tell your patient to stop smoking? You tell the patient to stop smoking not because of the lungs. Forget about the lungs. If you stop smoking, you have less heart disease, less stroke, and less cancer. And the bonus, you have some improvement in respiratory symptoms. So Mark Twain said that stop smoking was very easy. And like he said, I have done it 1,000 of times. So the message here is, you're going to talk to your patient and say, listen, you must stop. I have the tools to help you. The tools are going to require behavioral modification as well as pharmacotherapy. It's not going to be easy. It's going to be a lot of work. And you may stop, you may go back, you may stop, you may go back. I'm willing to help you all the time, anytime you need. Because some patients might require multiple interventions. All these interventions that you notice, we went from the pharmacological for nicotine supplement that stuff doesn't work because the way the patient gets the satisfaction is peaks and valleys, so it gives the urge. So now we're going more into the brain receptors, and that's what we do with the partial nicotine receptor with varenicline. There is a vaccine. There is a vaccine on the clinical studies that actually binds to the receptor. So nicotine has no effect whatsoever. They don't experience anything. They experience the same satisfaction as smoking and not smoking. So a lot has gone into that, focusing in the receptor itself, not on the nicotine. And that's what the varenicline studies. Okay, so what about pharmacotherapy? So we have to divide the pharmacotherapy, our drugs, in two large groups. Bronchodilators, and those want to divide it in short-acting. These should be limited for rescue only. And the long-acting beta-2 agonists, Solmiral for Morero. We may get another one called Indecaterol that is in the process to be approved by the FDA. We have one long-acting anticholinergic that is tiotropium. I can tell you in the pipeline there are 5 on the develop. And theophylline, we'll talk about that in a minute. And in the anti-inflammatory side, systemic corticosteroids should be limited for exacerbations only. In your maintenance therapy should be inhaled corticosteroids, and in some circumstances, patient will require triple therapy with combination. So what's the data to support all this? First, I know it's very confusing for us and our...
I have a question. But here in the VA, so first line is long-acting anticholinergic, tiotropium instead of ipratropium.
Tiotropium or Formoterol.
Yeah, but here on the VA, it's non-formulary still.
Yes, but you have Formoterol that is formulary.
Okay, but
So
on the anticholinergic, so is there a difference using the long-acting beta agonist plus the short-acting anticholinergic?
You should not give them. It doesn't work.
It doesn't work.
No, we won't do anything. You wanna give them short acting. You stay with this. Rescue. Don't give an anticholinergic.
Okay.
You need to use. You wanna use these two. The way they are coming, the new anticholinergics are gonna come. This is gonna come together.
Okay.
Lavas and lamas are gonna come like a single inhaler, a single delivery.
If they're on the formoterol, do they need, inhaled corticosteroid along with that? Since we have
I think we need to depend. I'm going to talk about that. When do they need it? Yes. Now, I can tell you one thing before I move. The studies have shown that clinical efficacious is better if you have fixed combined than you separate. So you give mometasone and formoterol, you give the dual combination, it is better to fix. And they have done prospective studies giving monocomponent and fixed component, all the outcomes, improvement quality of life, everything is better because there may be some synergies and not only compliance. So we had all this mess about delivery devices. This was in part triggered by the EPA. Many years ago determined that the MDIs were producing too much effect in the ozone layer, the CFC they were producing. I can tell you my refrigerator probably produces more CFC than all those MDIs together. So this has forced a change in the devices. I think there's a space. There's a seat over there in the back. It's nice and comfortable. So the devices have gone into powder. The devices have gone into HFAs. I can tell you that I always ask, what about my patient use an HFA? Can I use a spacer? None of the HFA medications have been studied with spacers because the FDA told them you study with spacers, you have to get approval with spacers, and your time of approval triples. So we don't know if using a spacer is better with the HFA that we have now. It may not be better because you may get more deposition of the drug in the spacer. So it may not be a preferred way to use with the spacer, but all the ones we have now are HFA. So that has not been studied. Just be aware of that, please. So this is the gold guidelines recommendation. Basically, across the board, everybody should have risk reduction, influenza vaccination, pneumococcal vaccination. Be sure everybody has got their flu vaccine by now. Go ahead and give it to them. And the pneumococcal vaccine every 5 to 8 years as a recommendation to revaccinate. As you can see, everybody has a ratio less than 70. It doesn't matter that your ratio is 69 or is 45. That doesn't tell you anything. What it tells you is the FEV1 itself. So the FEV1, you can have a normal FEV1 and have this group mild, that you're at risk, but you can have between 50 and 80, 70%, 30 to 50, and less than 30%. So the severity of the disease tells you by the FEV1. At the end of the day, your treatment is based on symptoms. So a patient with milder disease and has symptoms, you have to treat. So let me focus for a few minutes in this group, in the very severe, because here's when we have most of the data, and the data has shown most of the benefit. And the way I look at that is if I invent this wonderful product to decrease and improve, put air in your tire when your tire becomes flat in the middle of the freeway when it's raining, I'm not going to test the product until your tire is like this, flat, flat, flat. I can go in and be an hero, inflate your tire, and you keep going. So that's why the studies were done here. Now a question, I'm going to show you some data, is we're going to start moving towards the left. So how soon we can start doing all these interventions? And there is data emerging. So the one of the misconceptions is that COPD is not an acute responsive disease. And the definition used to be that you have acute response, you have asthma, you don't have acute response, you have COPD. You don't have to do acute response. Don't request bronchodilator response. It doesn't matter, that doesn't mean anything. In this study, what they did is they maximally challenged the patients. They have 4 puffs with albuterol, 4 puffs of ipratropium. 72% of the patients had more than 10% responded to FEV1. All these are COPDs, 100% COPDs. There were people that had around 100% response acutely bronchodilated. That acute response will not determine the long-term response, but that's what it matters to you. When the long-acting bronchodilators...
So the acute response to bronchodilators is not correlated with long-term response.
Doesn't mean anything. If they acute response, doesn't mean anything. If they don't respond, doesn't mean anything. So don't request it, don't do it. You want to make a diagnosis, some of the guidelines say you should use the post-bronchodilator FEV1. You just ask for a post-bronchodilator FEV1, and that's the number that you use as your baseline. But you don't care if there is an acute response or not. Now, other problem that we have in this disease is how the disease was studied. It was not until tiotropium came into registration trials that the FDA said, well, I don't want a 3-month studies. I really would like to have a 1-year study to get a picture of what's going on. When salmeterol was studied for 3 months, for mother was 3 months. So this is the first time we can see better, understand better what's going on here. So this is day number 1. Patient receives the medication, there is a response. But the reality, the money is what happened a year later when your patient walks into your office. Your patient, this was their baseline FEV1, they walk into your office 15% above what they were before, and still, they have an acute response. Well, you can say, well, the other group that received placebo actually received albuterol. So what about if you compare ipratropium versus tiotropium, the short-acting and the long-acting? Day number 1, both respond. Ipratropium over time, we start losing, tiotropium will stay there. But a year later, when your patients that are in tiotropium come to see you, they are 15% above, and they have the same response that they had before. Look at this. Your ipratropium patients have an acute response, but this baseline is already around 5 to 10% lower. So the lung functions start dropping and dropping. So you are beginning to lose ground. So it doesn't matter this acute response. This is what you want to achieve. Now what else? This has been reproduced with all the other bronchodilators. Here you have formoterol alone, formoterol with budesonide combined. Here you have salmeterol alone, salmeterol with fluticasone alone. So with all those medications you do, and actually when we have longer studies, and this is a 4-year study, we can appreciate that the slopes of the rate of decline are different. This is albuterol, this is combination, this is the products, the lines, and the amount that you lose per year is different. You go from losing between 50 to 60 mLs per year to losing less than 10 mLs per year. So you change that decline. Move and move and move. Okay, so what about milder disease? What data we have? The other day I was driving home, and the NPI has this report about how much money people lost in this recession. So talk about Gates, that he lost around $10 billion. For Gates, 10 billion less is probably, the guy is not crying. But on the other hand, they talk about this lady that she was a retired teacher, has saved all her life, and she had like 90K in her saving account, and now her saving account is like 40K. She has lost over 50% of that. So she will not be able to, and we're talking about she's going to do in really hard times. So the same thing happened to our patients with COPD. This is how much lung function you lose over time. And this is data has been compiled for clinical studies. It turned out to be people who had very severe, they don't lose. They can afford to lose. You're very severe, you lose, you die. So who are the ones who lose more? The ones who have more. So the patients who have FEV1s in the 60-70%, the decline is much faster than the patients who have more severe disease. They can decline more. So that's the rationale to start looking at these patients earlier before they decline. Just do this. So what happens when you look at pharmacotherapy? You have here that in this rate of decline in lung function, see, look at here. The very severe is almost no change. But here, in the patients who have more moderate disease, the albuterol group loses this much, the other group loses less. So you can decrease the amount of blood loss to is given with the short-acting. You have seen that graph probably many times. This was by Fletcher and Pito, that they proposed that the patients who smoke has a different rate of decline in lung function than the person who don't smoke. It turned out to be that you never smoke and never exposed to any environmental conditions. For your FEV1 to be 50%, you need to live 140 years. So we are made to breathe forever. We take care of our lungs. You can die of everything else but your lungs. Now the problem is this graph is not true, because the decline in lung function occurs in a stepwise, like this. And this is what exacerbations do. So I'm not going to show you the data, but the studies have demonstrated people who exacerbate have more rapid decline in lung function, people who exacerbate has worsening quality of life, and the exacerbation can be decreased by pharmacotherapy. So there are randomized trials that the endpoint has been exacerbation. In this study was compared LABA versus combination, and you have a 30% reduction in exacerbation. You will have an albuterol group here. The exacerbation will be 2 point something. You will have a 70% reduction in exacerbation in this group. And this has been shown with anticholinergics and has been shown to decrease hospitalizations. And in patients who have severe disease, you give triple therapy, because the recommendation in patients with severe and very severe disease is triple therapy. You having one group here was budesonide and tiotropium. The other one was placebo or tiotropium. So given that this is Symbicort and tiotropium, or budesonide, placebo and tiotropium. So you're given the triple therapy, the patients are going to be better off, having less exacerbation, better quality of life, and there are data that suggests that you can have a decrease in mortality. So with this pharmacotherapy, we are decreasing the mortality. Now, how this has translated what we do? In our winters, we used to have every week between 2 and 3 patients on the ventilator and a couple of patients coming on invasive ventilation. That was our winters of the late 1990s, beginning of the 2000s. We look at our winter of 2008 to 2009, we intubated 1 patient, and we had 3 on non-invasive ventilation. So we're not seeing these patients anymore. Actually, I have to tell my fellow, this is the way it used to be. But they don't believe me, that we used to have those ICUs full of people that have chronic lung disease and coming there. At the same token, the other day across the street, I had this gentleman who was admitted, and my resident said, oh, this is his 4th exacerbation this year. And I said, listen, stop. In 2010, this is not possible. Either the patient is getting inappropriate therapy, so that will explain, and we had a lady that every time she would come with her triple therapy, she will go home in albuterol and ipratropium, and nobody will fill her up with triple therapy until 2 months later when she comes with another exacerbation. So that when these patients leave, they have to leave with their appropriate therapy. In that particular case, the gentleman was taking appropriate therapy, so why he was having that frequent exacerbation? So we talked to the wife, and the wife told me he would get up every single night around 2 o'clock in the morning and start spitting up food. The guy, what he had is a horrible reflux. 3 times he had got labeled as a COPD exacerbation when the guy had aspiration due to reflux. When we did barium swallow, started from the bed, or the barium was already in his mouth. So we need to treat his reflux, we need to have his bed elevated, we need to do all that, and change the diagnosis for COPD exacerbation to aspiration due to reflux. Okay, so all this about lung function, mortality, exacerbations, looks great, looks fancy, but I can tell you, for him, it's worthless. He wants to do better. He wants to feel better. So, what do we know about these patients? Sorry if I don't let me just get it. So if you get the same age, the same comorbid conditions, all these patients have the same comorbidities. The only difference between group A and B is that a group who has COPD has an FEV1 that was severe, a mean of 43. The other group of patients has a normal FEV1. The COPD patients are in wall. So what do they do during the day? So they have this device that they measure the position and the level of activity. So they do 45% less walking, 35% less standing. You have to do something during the day. I mean, we are not in heaven. So they sit in 22% more, and they lay down 200% more. These patients get up later every day. These patients take a nap after they eat. These patients go to bed earlier, as compared with the same cohort. So the disease tremendously limits their daily life. And if you can assess and ask them any way you want, it limits their life on any aspect of their life. There's a lot of data now, sleep and the relationship with the disease, but it will limit the disease 100% any aspect of their life. So what can we do to improve, to make them better? Medications are improving quality of life. And any way you measure it, and here is by severity of lung function, the patients who have milder disease are the ones who experience the higher improvement in the quality of life. Rehab and exercise is the third leg of this therapy. As we talk about the smoking cessation and the pharmacotherapy, these patients have to move again. Ideally, you would like to do a structure of the program. We don't have a rehab program here, but you can say for fee-for-service, they will send it for me. I will authorize it, they will send it out. So the patient go to a rehab. If you cannot send it to a rehab, I tell my patient, listen, I need you to move. I need you to get out of your house, go to the mailbox once a day, and the next week, you're going to do it twice a day. The next week, you're going to go around the corner. By the time you come to see me in a month, you're going around the block 3 times a day. Because they have to, when they're breathing better, they have to move better. What about if you do rehab, or rehab dose improves any parameter, endurance time, distance, whatever you want to do, but gets lost over time if the patient don't continue. We thought we won a battle with Medicare. Last year, Medicare announced that they're going to fully fund the rehab, and not only the intensive phase, but also the support phase. But it turned out to be with the new healthcare reform, who knows what they're going to fund. But the reality is, whatever they do, they have to continue. So if you send a patient to a rehab program, a lot of the programs in town, they pay out their pocket between $10 and $15 a month. They will continue to be able to go and do it. And I think it's important for them to continue to do it. Once you put all this together and say, okay, I'm giving maximal pharmacotherapy, smoking cessation, and rehab, and I'm gaining more. And in this study, what they did is the group in red, they receive albuterol and ipratropium. The group of blue receive tiotropium. As well, they already have smoking cessation. You can see before they go to rehab, they are 16% better. After rehab, are 30% better. And when the rehab effect are beginning to lose, they can sustain that effect. So this slide shows you put all this together, you really can improve the patient's function. And this translates in improvement in quality of life. How this happens? You deflate your patients. When you produce prolonged, and the reason that bronchodilators work, the long-acting and the short-acting don't work, if the short-acting are not able to deflate the patients. The long-acting deflates the patient. You have a decrease here of FRC and RV that are in 600 mLs, something you can even achieve by surgery. You can clip a lung. You don't reduce that much volume. Pharmacotherapy, what you do is you deflate your patients. When you deflate your patients, you can breathe better, you can exercise better, and everything just goes down the road. So, in conclusions, this is a multi-component disease that is not limited to the lungs. This is a disease that our goal is to have the prolonged bronchodilatation to be able to deflate those patients. And that will translate to the improvement of everything else. Most of the studies have shown that the combination of the different factors are what the patients are going to do better. So you're going to try to tailor the therapy by severity of the disease. It has to be in triple therapy. Moderate disease, it should be in long-acting bronchodilators, either formoterol or tiotropium. We do have some head-to-head comparisons. Maybe the long-acting anticholinergics are better because you develop less tachyphylaxis over time. So you have the long-acting beta-2 agonists, you lose effect over time. The other ones is more sustained. but you have to use whatever you have available. I know we don't have in the formulary, actually tiotropium is approved in the national formulary, but here you have to jump for a couple of hoops to get it. But at the end of the day, your patient is going to be better off. Started with formoterol, the patient doesn't get better, add tiotropium. And to answer your question, inhaled corticosteroids, I forgot, I don't have the slide there. The data supports that anybody who's under the age of 50, under the FEV1 less than 50% should be an ICS. And the reason being was a study that patients were given tiotropium alone, a placebo, or they were given combination therapy. It turned out to be that the tiotropium patient had higher mortality if they had FEV1s less than 40%. So the reason you give inhaled steroids in the patients who are sicker is you give it a cardiac protective, potentially it's cardiac protective, their effect. So, and it increases mortality. So your aim is mortality that you are going to achieve. And there are almost now 3 studies now have demonstrated that these patients, when they are inhaled steroids, they have less cardiac deaths, cardiac-related deaths. So I mentioned before what you want to remember, so I hope I convinced you that this is a preventable, you stop smoking and treatable disease. This can be reversible. By 10 to 15% at the baseline, you can improve and further add improvement, as well as you have to add all these together for the treatment. And your ultimate goal is you're going to modify the disease and let these patients live a full and happy life. I'm going to stop now.
Thank you very much.
Any questions? Yes, ma'am.
They have formoterol, all of them, right? All of the COPD patients then should be on formoterol.
Yes, ma'am.
Will they also need albuterol for a rescue?
You want to give it as a rescue, and I emphasize to them there is a rescue.
Okay.
Now, I know a lot of patients like the nebulized. They feel better. The studies have shown that the lung deposition is higher with HFAs or powder than nebulized. When you see your patient with a nebulized medication, you see all this stuff coming out there, that's the medication that's coming out there. That is getting there. So you get more. So if the patient insists and wants to have a nebulized, there is a formoterol nebulized solution that is actually in our formulary here. We have it available. We have it available for an inpatient. You can prescribe for an outpatient. There is a problem with the patients with Medicare. Medicare, they get for free albuterol and ipratropium. So my Medicare patients come and tell me, listen, I have to pay for this, and I have to pay $50, $60. I get it for free, the other ones. I tell, well, it's very easy. Your FEV1 is 800 mLs. If you continue taking albuterol, ipratropium, you're going to lose between 50 and 70 mLs per year. You will be back to see me in 2 years because you need oxygen, you need scuti, you need severe incapacitation. We can hold that. You will have to pay now, you're going to pay later. That's what it comes down to. You get that for free because it doesn't work. That's the reason you get it for free. But there is no free lunch. That's the bottom line. So that's and we need to emphasize. So ideally, you would like to have the long-acting anticholinergic on board. But if you are in formoterol, you are 100 miles away than being on Conviven or albuterol and ipratropium. Anything else?
So smoking cessation pharmacotherapy, how often are you guys prescribing these?
So we do have, actually in the institution, a smoking cessation clinic. The patients I'm going to invite to come, they will have to do the behavior modification because it doesn't work just to give it a pill, to get anything. So we have purposely forced on all the pharmacotherapies given by the smoking cessation clinic because it has to have the behavior modification. At the mark, my private practice, what I tell my patients is, I need you for 1 week for you to write what you do when you smoke. And then what I try to do is I try to change the habits because smoking in some of these patients is embedded, like the way they walk, the way they talk, the way they comb their hair. I mean, it's part of your life. I mean, that's what it comes. You're not putting away something that is embedded inside them. So you start changing some of the routines around. So they get up in the morning, have a cup of coffee, and have a cigarette. They get up in the morning, go directly to the shower. They switch coffee for tea. They do other stuff. So you start kind of moving. And then when they have to be ready, and they have to tell you, I'm ready to stop, then you start having the intervention. What we learned in the Varisicline trials is that the success rate of being smoke-free at the end of the year will be increased if you repeat the treatment 6 months later. So you do another course of pharmacotherapy. You can double the chances of the patient to be smoke-free. Some people don't it. I had a gentleman that he's one of the sheriff in one of the towns south of San Antonio. He would walk into my office all the time with his M's in his pockets. And I say, Mr. F, you don't have to go. He knows that I see him around 1, 2 o'clock, and normally I don't have lunch, so he brings a bag of chip nuts, and that's what he brings to me, or chips, and he gives it to me when he walks in, and I say, here, the chips, don't say anything about my smoking. I would take the chips because I'm hungry, but it has to go. And one day he came in without it, and I say, Mr. F, what happened with your friend? Oh, Doc, I had a heart attack like 6 weeks ago. I thought I want to die. I will never, ever want to do that. We tried 3 times to stop. He had done everything. He even did hypnosis, and he had done everything. So he was never fully convinced. When he saw that they were knocking on his door closer, he was fully convinced, and that's when he stopped smoking. So they all have to have something, and they have to be 100% committed to go into it. Otherwise, it doesn't work. And I tell them, your significant others, if they smoke, outside. Nobody smokes in your house. They want to smoke? Stay outside. Just don't let them come in, and if they smell bad, tell them you smell bad. You better take a shower. Just kind of start forcing that, create an environment. It's amazing when you see it, you ask yourself, if this stuff works? We don't see it here, because in the States, it's socially unacceptable to smoke. If I could have come here, and I have pulled out my cigarettes, and start lighting up here, you guys will freak out as I will start taking out my clothes. I mean, it's going to be as equivalent for that, because it's completely socially unacceptable. But when I travel, I can see the changes in Europe. For example, Europe, there was a place and people would smoke them all. I mean, you can see how, like Italy 4 years ago, it was banned of all the restaurants everywhere. In the beginning, when you walk into the restaurant, they had all these tables and people were smoking there and running back in, and people would go back in. And you say, this. You go back, you don't see that anymore. I mean, the people are really, they are the ones they understand, so slowly get it. So you can see all these impact societies, impact behavioral groups, and really eventually may have something good for everybody. Very often I have a friend or especially a spouse of a wife, they will tell me, tell her to stop smoking. I say, no, I want you to smoke. So I want you to be my patient. So if I stop smoking, I will run out of patients. So I need you to smoke. I need to generate the new, unfortunately, the new generation is being bred today. The large number of smokers today are under the age of 30. You only have to do is go to any youth events. Many years ago, before they were banning discos, I went to my wife to a disco here, and it was unbelievable. I mean, the whole dancing place was completely fogged, not because they have a fog machine. It was all of smoking. So that's the problem. The new generation is being bred now.
Okay.
Thanks a lot.
Thank you
Have a
very
wonderful
much.
day.
Everybody, please sign.